Okay. Let's you talk about preterm premature rupture of membrane and chorioamnionitis. What are the drugs they are using in this preterm premature rupture of membrane and chorioamnionitis? Introduction. The preterm premature rupture of membranes (PPRM) is a spontaneous rupture of membranes prior 37 weeks of gestation. Therefore, we are often need to continue pregnancy with conservative management till the fetal lung maturity is obtained. Here the amniotic fluid is normally sterile, but when there is prolonged rupture of membrane, there are chances of ascending infection from vagina which can infect the residue and lead to chorioamnionitis. The chorioamnionitis is notoriously difficult to diagnose. It comprises mainly of maternal pyrexia more than 38 degrees centigrade or at least 2 of either of the following. If it's maternal tachycardia is pulse rate more than 100 beats per minute, fetal tachycardia more than 160 beats per minute, uterine tenderness, offensive vaginal discharge, raised CRP, raised maternal TLC count. In women with PPRM, timely initiation of antibiotic prevent the development of chorioamnionitis, a dreadful clinical event. Also, when a PPRM is at less than 34 weeks of period of gestation, corrective steroids are required for fetal lung maturity prior to termination. When chorioamnionitis is clinically suspected, pregnancy has to be terminated. Simultaneously, woman is started on antibiotic. The choice of antibiotic is usually in the line with postpartum endometritis, as both are caused by ascending infection. Spectrum of causative organisms in both conditions are same. What studies have to say? The Oracle trial was the first acceptable study to demonstrate the role of oral erythromycin in PPR regimen. Remember the Oracle trial. Oracle trial is the study that is the role for oral erythromycin in PPR regimen. This was large randomized control trial which included 4,826 women with PPRM in singleton pregnancy. Erythromycin alone was associated with an insignificant reduction in neonatal mortality and morbidity, whereas the co-amoxicillin was associated with significant rise in case of necrotizing enterocolitis. The Oracle 2 trial has laid a guideline on the use of broad spectrum antibiotic for spontaneous preterm labor. Though there is no good trial to guide about the best place for management of PPRM, but as it recognizes that 48 to 78 hours is the critical time during which women will go in labor or develop clinical chorioamnionitis, it is recommended to manage them as an indoor patient during this stay of intravenous. Intravenous antibiotic are used for at least 48 hours followed by oral antibiotics. The antenatal steroid are associated with a significant reduction in the rate of neonatal death, respiratory distress syndrome, and intraventricular hemorrhage. A specialty with single course given between 26 to 34 weeks of gestation is safe for mother also. They are most effective in reducing respiratory distress pregnancy that deliver 24 hours after up to 7 days after administration of the second dose of antibiotic corticosteroid. This is the antibiotic recommendation PPRM in chorioamnionitis. Preterm choice of antibiotic doses. Preterm premature rupture of membrane. Drug of choice is erythromycin. It is effective against most gram positive and few gram negative organisms. Highly effective against streptococcus, pneumococcus, gonorrhea, chlamydia and mycoplasma. The dose is 250 to 500 mg erythromycin IV every 6 hourly for 48 hours, then for 250 mg orally for 6 hourly for totally 10 days. If you start IV dose, you can start with IV dose for 48 hours, 6 hourly, then you can change into orally for 6 hours for total 10 days. Additional therapy, if vaginal swab grows group B streptococcus, if you get in the vaginal high vaginal swab, you get group B streptococcus, ampicillin or any penicillin can be added except co-amoxicillin, that is increase the incidence of necrotizing enterocolitis in newborns. Ampicillin and solbacin is another alternative. Ampicillin is doses 0.5 to 2 gram. 0.5 to 2 gram. Remember this dose. 0.5 to 2 gram IV every 6 hours for 48 hours. 0.5 to 2 gram every 6 hourly for 48 hours. Then 0.5 to 2 gram orally 6 hourly for 10 days. Initially 48 hours every 6 hourly, 0.5 to 2 gram for 48 hours. Then you have to continue for another 10 days. Second line, if patient is sensitive to penicillin or erythromycin or ampicillin, you can change to clindamycin 600 to 900 mg, 600 to 900 mg IV 8 hourly for 48 hours followed by 150 to 300 mg 4 times a day for total 10 days. Then, if the patient already is diagnosed with chorioamnionitis due to the high vaginal swab or placental culture report, and drug of choice is ampicillin, gentamicin or metronidazole. The combination provides a broad spectrum antibiotic coverage for gram positive and negative organism and NRO. You give a triple antibiotic, that is ampicillin 1 to 2 gram IV 6 hourly, 1 to 2 gram IV 6 hourly ampicillin. Gentamicin 1.5 mg per kg. Gentamicin 1.5 50 70-80 around mg per kg per day. IV 8 hourly. Metronidazole 500 mg IV 8 hourly. This is the dose. Ampicillin and ampicillin is 1 to 2 gram IV 6 hourly. QID. Then gentamicin 1.5 mg per kg body weight every 6 hourly, every 8 hourly. TDS. Ampicillin is QID, gentamicin is TDS, then metronidazole is 500 mg IV TDS. Okay, remember. Then the second line, if they have all allergic reaction to penicillin, then you can go to cefotaxime 1 to 2 gram IV or IM 8 hourly, or ceftriaxone 1 to 2 gram IV IM 8 to 12 hourly, or cefuroxime 1.5 gram IV or IM AV TDS plus metronidazole 5 mg IV TDS. If patient does not respond to above regimen, imipenem plus cilastatin. After the, if they fail to respond the treatment of ampicillin and gentamicin and metronidazole, you can change to imipenem plus cilastatin or piperacillin and tazobactam. If MRSA is suspected, you can add vancomycin, teicoplanin or linaclotide. The treatment is continued for till 24 hours after the patient becomes hyperfile. Remember the chorioamnionitis treatment: triple antibiotic, ampicillin 1 to 2 gram IV QID, then gentamicin 1.5 mg per kg body weight 8 hourly TDS, metronidazole 500 mg IV TDS. If they react to penicillin, you can go cefotaxime, cefuroxime, ceftriaxone or plus metronidazole. If patient doesn't respond after the treatment course, then you can change it to imipenem plus cilastatin or piperacillin tazobactam. If MRSA is suspecting, then vancomycin, teicoplanin or linaclotide you can give.